Dear friends, in this lecture, we are going to discuss about mechanical power, which has become a very important concept whose change matters a lot in mechanically ventilated patient. Let us start with the illustration of a case. A 30-year-old male, a polytrauma victim with fractured shaft femur, having pulmonary contusion, blunt trauma abdomen for 1 day, presents with shallow respiration, tachypnea, ascites, low blood pressure, tachycardia, and fall in saturation. Patient is initially resuscitated with fluids, RBCs, vasopressors, abdominal and chest drains are inserted, and patient is mechanically ventilated using low tidal volume and keeping the plateau pressure, titrating the plateau pressure at lower than 30 centimeter of water using the assist control volume mode. Although there is initial improvement with a rise in saturation, fall in the respiratory rate, and a reduction in the driving pressure, after 12 hours, there is no further improvement in the SpO2. There is resurgence of tachypnea, unchanged plateau pressure, and driving pressure. And after 24 hours, there is seen a fall of saturation with no change of plateau pressure and driving pressure, with subsequent deterioration after 48 hours, with severe fall in the saturation and rise of plateau pressure and driving pressure. Now, this scenario is not very uncommon and frequently in many patients who initially seem to settle down with the necessary treatment and mechanical ventilation, whether volume control or assist control or pressure control assist. But subsequently, over a period of 2 days or 3 days, they seem to take a U-turn and they usually their condition worsens. Now, what causes this worsening after initial improvement? Now, to understand this worsening, one have to understand the inadequacies of driving pressure in monitoring a patient on mechanical ventilation. We all know that driving pressure is relatively simple means to monitor mechanical ventilation, and its association with mortality is quite well demonstrated. In fact, whenever the driving pressure is reducing, we infer that the mechanical ventilatory strategy is working well. And when it is going up, it indicates that the mechanical ventilatory strategy is probably needs to be changed or altered. Nevertheless, reducing driving pressure as well as ventilation with a lung protective ventilation of less than 6 ml per kg usually leads to an increase in the respiratory rate. And to reduce this hypercapnia, most clinicians resort to increasing the respiratory rate. And this increase in respiratory rate is associated with a increase in the mechanical energy from which the mechanical power is derived. So the effect of additional parameters such as the tidal volume, driving pressure, PEEP, plateau pressure, or flow on the ventilator's contribution of lung injury is currently an important topic of research in the field of mechanical ventilation. And it is on this perspective that more clear idea of mechanical energy needs to be understood at the level of the operator. Now, the first law of thermodynamics states that the change in internal energy of a system equals to the heat added to the system minus the work done. Or in other words, that the heat is conserved, it is not lost. Now, this heat, if it is not used for the purpose of work done, it will be used for other purposes. So during mechanical ventilation, we know that electrical energy changes to potential, kinetic, and heat energy. And this pressure generated is the work done is to move the volume of air, which is known as the tidal volume, into the lungs. Now, this transfer of energy may affect the lung parenchyma to make structural changes at the cellular and the tissue level, and that is what contributes to ventilator-induced lung injury or VILI. Now, this we have to be careful about and understand the mechanical power in reducing the ventilator-inducing lung injury. Now, why is this mechanical power important? Many parameters contribute to this ventilator-induced lung injury, but there is a growing evidence to show that out of this, the respiratory rate, the airflow, and the strain, that is the cross-sectional width of the air that is pushed into the alveoli, that is important. And the combined effect of these parameters represents the mechanical energy of the ventilation. So the effect of mechanical energy generated by a ventilator on the respiratory system depends not only on the ventilatory settings, but also on the properties of the lung, such as a lung which is consolidated compared to lung which is healthy will reflect a different kind of property. And as a result, the effect of this mechanical energy is likely to be different. Now, high mechanical energy is associated with poor outcomes, and this could be used as a prognostic parameter and indicator to assess the risk of ventilator-induced lung injury. Now, this energy, which is transferred from the ventilator to the lungs per individual breath, is termed as mechanical energy, and the energy which is transferred per unit time is the mechanical power. Now, if you see these two conditions, you see the diagram A and the diagram B, you can see very clearly that the area which is the aerated area and the non-aerated area combined is much bigger in the lung at figure A in comparison to the figure B, where the consolidated area is much bigger. Therefore, since this excess energy in the form of heat it is dissipated in this aerated and the non-aerated area, because this aerated and the non-aerated area are able to accommodate this energy, then the chances of this causing the villi is less. So since this is much more in the lung at the figure B, the chances the lung B can be seen to be as more prone to ventilator-induced lung injury as against the lung depicted in the figure A. Now, how do we measure this mechanical power? There are both quantitative and qualitative methods, and none of this method is foolproof, because the quasi-static measurements which relied upon the pressure volume curves of the respiratory system were easy to calculate, but they had the distinct disadvantage because the potential energy creating the static strain within the respiratory system could not be calculated, and there was a need for inspiratory maneuvers which becomes evident, which becomes more clear in the low flow conditions, and barring which this could not actually clearly assess the mechanical power. Similarly, the other methods were also enabled the measurement of the mechanical power partially, but they also had certain disadvantages because the distinct components on the power are not inherently predictable. That is, in simple words, in a particular system, whether the component of respiratory rate is more, or the flow is more, or the strain is more, because each of them is going to variably influence the system and increase the amount of mechanical energy. Unless that can be individually calculated separately, it becomes difficult. So therefore, these were the problems. And then gradually it became clear that if we can rely upon that the change in volume versus the respiratory system, the change in pressure, that is the compliance can be in the more newer ventilators, as you can see in this diagram, that the change in volume is from 0 to 10 and the change in pressure is from 3 to 30. So the total area of the curve is calculated by multiplying 10 into 27, that is 270 centimeter of water. And out from that, if we eliminate the area from the PV curve was calculated, which comes out to be 174, because by subtracting the total area, that is 270 minus 174, and this yielding the white area, that is the 96 ml. So this is the area where this energy transfer has to be dealt with. So this is the calculation on the basis of which the newer equations are relied upon. Now, the more recent calculations, the more recent ventilators, because they use the resistive component, the elastic component, and the PEEP volume separately to delineate the individual contribution of these factors to the mechanical energy, takes the separately, considers the elastance, the resistance of the airway, the respiratory rate, the change in volume, and the PEEP. So all combined, it gives us a value which is very much near normal to the mechanical energy under all situations. Now, the concept and calculation which was proposed by Professor Gattinoni way back seems to be quite valid, because in this calculation, there has been due consideration on the tidal volume separately, elastance of the respiratory system, the IE ratio, as well as the airway resistance. And according to all the trials and the fundamental researches, the translational researches, the mechanical power, which was calculated by Professor Gattinoni, that is found to increase exponentially with the respiratory rate, flow, tidal volume, and pressure difference, and linearly with relation to the PEEP, which means that probably the contribution of PEEP as a cause of increased mechanical energy and the likely risk of VILI is slightly less in comparison to the others. So despite numerous other proposed calculations, this calculation by Gattinoni is still considered as one of the most accepted calculation for mechanical power. Now, one thing needs to be understood that mechanical power in the pressure control ventilation and volume control ventilatory modes can be different. The PV loop from which this mechanical power is reached is different between these two ventilatory nodes, because in the volume control ventilation, the tidal volume remains constant, but the pressure varies depending upon the alterations on the respiratory mechanics, that is the elastance and the compliance. On the other hand, the flow pattern in the pressure control volume has a decelerating character, which results in the different loop or PV loop. Now, Gattinoni's calculation is an approximation and it is valid only for volume control ventilatory modes. And for pressure control ventilatory modes, there has been a different equation which has been proposed by van der Meijden, and that takes into account, in addition to the other factors, inspiratory time, because this inspiratory time will be the determinant factor is prolonged, so therefore becomes an important factor in determining the determining the expiratory component of a fraction of the equation. Now, if we look into these two modes, and if the top panel represents the pressure time curve, the middle panel, the flow time curve, and the bottom panel, the weight of the different power components, we can clearly see that in volume control versus pressure control, the resistive component is clearly different. The elastic component may or may not be different based upon the amount of ventilatory support in pressure control, and the PEEP, of course, remains independent. So therefore, these two equations need to be separately calculated if the patient happens to be in different modes of ventilation at different points of time. Now, this mechanical power as a non-invasive bedside quantitative tool as a potential for risk of VILI has been demonstrated, and it seems that the ventilator-induced lung injury occurs when the strain and stress surpass the tissue tolerance limits. Now, since different tissues will have different tolerance limits from different conditions, it is very difficult to reach upon a single-digit value at which we can shoot, but still, it has been seen that the power transferred to the patient's lungs from the mechanical ventilator does not occur slowly, it occurs very abruptly. And because it abruptly, therefore, it is good enough to create or to delineate the time and understand and to keep this tolerance limit within normal. Now, power transference relies on the ventilatory quantitative parameters like the tidal volume, PEEP, among others, and all of this can be adjusted at the bedside to mitigate the risk of VILI. Now, Cresoni et al. Demonstrated that a high transpulmonary mechanical pressure induced VILI after a threshold of 12 joules per minute, whereas Sarpaneto found that in ventilated patients with ARDS, a larger mechanical power beyond the threshold resulted in consistent increase in the mortality. So whatever it is, whether we take 12 or 17, we should be able to adjust the ventilatory settings based on estimated or calculated mechanical power by altering the variables for the parameters which are involved, and accordingly we can choose upon the number that we think is appropriate. But for all possible cases, for if the patient is having ARDS versus non-ARDS, then extra precaution should be taken, and a level of 12 to 14 would be appropriate, beyond which the power should be reduced. Now, what are the strategies to reduce this mechanical power? Either by reducing the production of CO2, which can be in the form of sedation, analgesia, paralytics, or fever control, or enhancing the ventilatory efficiency by reducing the dead space and achieving the best match for tidal volume at the respiratory rate. All the major clinical trials so far which have been published, which has been looked into the power, like the Guerin study in 2016 looked into 787 ARDS patients who were independently in two independent randomized control trials, the Accuracies and the ProSeva, and there was no safe dose of mechanical ventilation. And likewise, in 2018 and 19, the other two studies, one of which was from the MIMIC 3 and the EICU database, and another was from The ARDSNet protocol, the effects of mechanical power on villi was dependent on the functional lung size and also adds information beyond volume and pressure. So all of this have actually accepted the utility of mechanical power and tried to contain mechanical power within reasonable limits to reduce the risk of villi. The current progress and limitations in mechanical ventilation, because of this, safety thresholds of mechanical power probably vary with different lung conditions, and an accurate and convenient algorithm for mechanical power calculation based during assisted ventilation is a need of the hour. Components of the mechanical power contribute unequally, and this has been clearly shown by Gattinoni, and it requires a deep understanding the molecular mechanism of villi to understand this one of the related factor which may be adjusted preferentially over another when the safety threshold is either exceeded or likely to be exceeded, because you may have to adjust both tidal volume, respiratory rate and PEEP, but once you know the preferentially which one would likely to cause more benefit and least harm, it becomes easy to do that. While high power is associated with villi and worse outcomes, low power does not exclude the possibility of lung injury, because lung injury can occur in due to reasons other than this excess heat energy that is dissipated. So my take-home message would be that the degree of lung damage in villi can be linked to the amount of energy transferred from the mechanical ventilator to the respiratory system within a given time frame, which we call as mechanical power. There are several ways of calculating mechanical power, from the simple formulas to complex equations. The ideal tool would be the availability of esophageal pressure to measure the energy applied to the whole lung, then the whole respiratory system, to the lung, then to whole respiratory system. And regardless of the way it is calculated, not all alveolar units will be exposed to it, and efforts should focus on normalizing the mechanical power to the lung surface area, which is amenable to ventilation. Thank you very much.